Welcome back and welcome to this session on health AI, safe, scale, and pace. This session is hosted by Bleddyn Rees, who you know very well. Bleddyn is the chair of Digital Health Society, and he's also deputy chair of the European Connected Health Alliance. Bleddyn, I pass to you.
The next session is Health AI, Safe, Scale, and Pace. It's my pleasure to introduce Rachel Dunscombe. Rachel is the CEO of the NHS Digital Academy and the global lead for the Class Arch Collaborative, a group of organizations creating academic quality evidence for digitalization. She was formerly the CIO of Salford Royal NCA Group, one of the two most digitally mature organizations in the NHS. She has worked across the health and care system, as well as private sector and Europe. She is currently a visiting professor at Imperial College London and a member of the UK government's AI Council. Rachel, over to you.
Thanks, Bleddyn. And today I'm going to be talking about safe, scale and pace in AI. And it's something that I've been dwelling on quite a lot from my various roles within the UK government and healthcare systems. So the iceberg of AI, this is sort of the metaphor that I use for where we are with AI. We see the real exciting possibility at the top. You know, everyone talks about these algorithms and how they can improve radiology or risk stratification for individuals. But what we don't talk about is these sort of hidden aspects, the feeding, the watering, the maintaining. And below the iceberg, we have, the governance and quality assurance. So I've been looking quite extensively at safety systems, the data. AI is only as good as the data that you run over it. It is a bit like the old adage, you are what you eat. If AI or algorithms are fed poor data, they get poor outcomes or perform badly. And also the system and patient levels. We need to understand how AI actually changes human work, how clinicians and patients change the way that they interact, and also aspects of ethics as well. So that iceberg of AI is always worth considering. When somebody says, we've got this great new algorithm, we've got this, great new way of actually using intelligence, what are the true sort of implications of owning it? And for me, when I'm working with boards, I quite often say AI is like a junior doctor or nurse. Yeah, you need to have it managed and supervised. It needs to work in a narrow band, typically a ring-fenced area. You need to be able to audit it. So its performance needs to be audited. And you need transparency and oversight. So it's very much like a junior doctor working on the ward with supervision of a consultant, or a senior doctor, a junior nurse who's being trained, working with supervision. And, we can't expect, in the case of AI, all of our doctors and nurses to understand the lingo, the terminology. So we need to develop some standard ways of actually expressing what AI is doing, how it's working. We don't want to have to, give master's degrees to all our doctors and nurses who are supervising AI. We want it to be as easy as managing a junior doctor or nurse. And because of that, I created this lifecycle management sort of model for, how we should manage our intelligence and AI. If you actually look at intelligence and AI, many of you will know that we do an initial sort of approval, a sort of medical device approval, a CE mark, an FDA mark. And that approval happens once at the beginning. It happens over one set of data in one scenario, and it proves that an algorithm can work, in a point in time, in a place in time. But what we need to do over the life cycle, i.e., the whole sort of time that we use it, is continue to life cycle manage it. It's a bit like a nuclear power station for me. There's, the management of this ongoing until you decommission. And I've created 6 areas that I think are really useful to think about when you're looking at how you lifecycle manage a set of intelligence for AI. The bias detection, clinical safety, pathway performance over time, clinical audit, new demographic validation, and explainable un blackboxing. I also think it's quite useful to think about imaging data, structured clinical data, and operational and corporate data. The reason is those areas are in different maturity of AI development and probably also have different risk appetites. Understanding how you use AI over operational data may be, a whole lot less risky than clinical data. Imaging and AI is moving forward at a pace, but structured clinical data is probably more extensive in the data types it has, and there is more consideration about how we use that. So it's slightly behind the imaging data. Now, coming to clinical safety, we need to really understand how we relate clinical safety to the algorithm or intelligence. We already have clinical safety processes and governance within our organizations. And we need to work out how we can reuse what we do today in clinical safety and apply it to AI. So we need, sort of transparency over the AI to make sure that clinicians and management can see the safety and the performance of what we're doing. For me, that's very much about considering your governance today and what will work in the context of AI and what needs to be built towards the AI. But for me, building an AI governance that is parallel to your existing governance doesn't work. You need to sort of plumb in AI governance to your existing governance, and that includes clinical safety. So typically you need to have a regular reporting in line with your existing reporting on clinical safety for your analog services around the performance of AI in the clinical domain. And this is something that I've had the privilege of working on with some of the NHS organisations and helping, boards and other execs to understand how they should relate to clinical safety of AI. The next is bias detection. Now, bias is something that we hear a lot about. We need to work out how we're going to deal with bias because many algorithms have bias in. And here I sometimes say it's a little bit like vaccinations. When people are vaccinated, the people that have an untoward sort of reaction to the vaccine are probably different people to the people who would have been affected by the disease itself. Overall, fewer people are, impacted or harmed, but it's a different set of people. And so bias detection can come in many forms. It could be ethnicity, age, it could be to do with, economic circumstances. There could be many things that impact bias. What you need to do is have oversight of bias, and this requires tools and/or people like data scientists, or training up your clinicians to be able to spot clusters of groups of people who are not having the expected outcome. And that is really important to make sure that that data can be accessed and used to look at who those populations are who are not getting the right sort of, outcome from AI. We quite often find that people are adverse to using AI if they believe there is a bias in there. But actually what can be very helpful is working out what the impacted groups are and perhaps providing an analog service for them. So for instance, if we find that an algorithm doesn't work for people who are under 21 because they're still growing, could we provide, face-to-face clinician service for them and use AI for people over 21? So we need to think about how it impacts the services we design. But overall, we need to consider, how we train our algorithms and then how we measure bias and detect bias and keep oversight of bias during our life cycle of the use of AI. Another interesting piece is new demographic validation, and this is something really real for me, having worked across boroughs that are vastly different in terms of their socio-economic or, you know, sort of gender or age or sort of international representation in terms of populations. So when we said that we get a CE mark or an FDA approval, it's over one set of data, it's proven. But you move algorithms out, you extend it, indeed your population changes, you get immigration, you know, changes in, you know, the sort of place that you use this. So safely operating something in North America may be very different to China or indeed South America. And bias in new data sets has to be sort of validated. So as you take an algorithm to a new population or as your demographic changes, you need to revalidate. And that is really important. If you run a service in Ireland and you take it to England, then it needs to be tested again because we have very different populations in parts of England to say Ireland. And so that needs to be built into your life cycle management and your governance to make sure that each step we take to extend this or each change that we see in, you know, the populations that we use it over, we are really being rigorous about its safety and quality. Unexplainable Blackboxing. Well, this is what I kind of call the ingredient list. And actually, Google have done quite a good job of creating for general AI a sense of explaining what the AI does, which is nice. But, you know, when we pick up a food packet, we get an ingredient list. We get, you know, sort of the fats, the carbohydrates, the, you know, all of the things that are in it, the allergens as well. So the people that shouldn't use it. What we don't have at the moment is a standard sort of explainable set of parameters around how an AI works and what it does. And we need to actually move towards those common standards. We see, you know, in many fields we're getting common standards, but AI in healthcare, we're yet to develop those. There are, you know, early pieces of thinking around this, and indeed other industries have started moving forward. But when I talked earlier about not wanting to have our nurses and doctors all to have, you know, a master's degree in data science to understand things, we need to make sure that we're describing adequately what's happening within the box so that they don't have to sort of go to extraordinary lengths to actually interrogate the workings to make sure it's safe. And so, you know, as algorithms change, as they update, eventually one day as they self-update, we will need this sort of set of explainers that are very clear and very standardized. And I look forward to participating in whatever groups get involved in doing that. But that's one area that I think we've all got an obligation to support, you know, global standards on to make sure that we're all speaking the same language when it comes to how AI operates. Clinical audit. So clinical audit capabilities are very important for AI, and this is the oversight piece. So we audit our doctors and nurses on their outcomes, their performance, and we sort of provide audit functions within organizations, providing tools that audit, you know, the sort of outcomes of algorithms mean that we understand its performance. And it does come into clinical safety, but it also comes into the wider sense of how and where these algorithms can be used and how they may be extended and what the possibilities are. Clinical audit, I think, is also really important because it will help highlight where algorithms are providing much better outcomes or can augment humans in new ways. A clinical audit system is essential for any organization. And again, this is one where with clinical audit, we need to move our processes and governance towards our existing clinical audit processes within organizations. Pathway performance over time. Now, I know some of you may be, you know, exposed to the IHI quality improvement methodology or other quality improvement methodologies. I've certainly worked in quality improvement organizations, and what is very nice about what they do is they work out as rapidly as possible whether an intervention is safe, effective, and how effective it is. So they baseline, they provide run charts, and they work out, you know, how effective they are being with the intervention. With us, we need to take some of those methodologies and use them rigorously for AI. We need to baseline. We need to look at the change, the human change and the AI change. We need to look at the new pathway and its performance. And then we need to keep tracking it and improving it indeed, in terms of how humans and AI interact. So how we're augmenting our clinicians, for instance. We need really to make sure that we have the skills within our clinician base, especially those that are working with algorithms, to understand what data is implicated and needs to be collected around pathway performance, and to be given the time to baseline pathways before we put intelligence and AI in. This is the only way we will responsibly improve healthcare. And we certainly cannot, deal with the lags of innovations in medicines where it's taken 8 or 10 or 12 years to go from, early tests through to mass deployment. Quality improvement methodology is one way that we can do that. And that will give us our pathway performance over time so that we can keep our eyes on the prize of actually improving how AI works with humans. And the reason I say that is one of the biggest factors about how successful AI will be is that we need a handoff between humans and intelligence. How we embed that intelligence into the human process is one of the key success factors. And actually with some of the work I've done with class, that shows that it's actually really the difference between success and failure is, making sure that the human workflows and processes, the faith in the algorithm, and indeed the ability to understand how the algorithm is augmenting their work is really important. And pathway performance over time is really part of the tooling to reflect on that and ensure that you're tuning the optimal sort of combination of AI and humans. So to summarize, we've got a number of things that we need for safe, scale and pace in AI. We need, first of all, to make sure that we're getting clean, codified real-time data for our platform and to maintain that data ongoing. So that data needs to be as good as we can get it. Where possible, machine readable as well. Some algorithms are able to interpret non-machine readable data, but as we move towards the machine readable age, we need to be able to codify that. The AI is only as good as the data it receives. So if it's receiving incredibly poor data and the data quality is not good, then we end up in a situation where we have to, look at poorer outcomes. So it's very interesting for me. Data is now being regarded as a capital asset by certain governments. For this reason, it becomes the bedrock of AI and intelligence. And it allows you to actually capitalize solutions on the data as well as you create them in a way we couldn't do before. That's important because data is now going to be used many times for an individual. So for instance, a blood pressure reading when I was young was just take months when you went to the doctor. Now it'll be used as part of a series pattern for me as an individual to look at whether I'm improving, getting worse, how that relates to my other conditions. And so that clean codified real-time data is something that we need to get in order. And one thought for you now is, how are you getting your house in order today so that you're getting data ready for the machine readable age? While AI is not coming at scale and pace yet, we have time to get our data ready so that we're providing safer outcomes from these algorithms. The next piece is governance. You need to look at lifecycle management, and you need to consider what it will take in terms of the governance and the processes and the systems from the day you deploy it until it's decommissioned. It's also really worth considering what the total cost of ownership of an algorithm is, because you may see that tip of the iceberg. You may see, oh, well, it's going to cost me, I don't know, $40,000 a year or 50,000 euros a year. But what is the total cost of ownership once you've taken, into account the curation of the data, the governance and the life cycle management? What will it cost to own, and what are the benefits that will be gained when you do this at scale? and you have the right systems to do it at scale. So governance for me is one of the things I spend a lot of time on. People think that when I talk about the AI Council, I work on really funky algorithms and exciting stuff. Most of it's about governance and data, actually, making sure we have the bedrock right. Finally, skills in the workforce. We talked about not wanting to have all of our doctors and nurses needing an advanced qualification in data science to run these things, but they do need a basic awareness, and some of them will need some advanced training. We need to make sure that we're providing the education that everybody needs to understand how this can augment their practice, where they should be embracing it and using it, and also providing those with an interest with clinical safety in the digital world, the training that they need to be clinical safety officers and algorithm owners. I think one of the most exciting jobs for me in the future world will be the doctors and nurses that own algorithms, manage them, maintain them, and supervise them, a bit like the junior doctors and nurses. So those people that, are really the sort of ringmasters of the AI world from a clinical perspective. We need to train those people at med school, nursing school, and other places to make sure that they have the skills they need to feel that they can actually master that task. But once they do, that will provide great benefit to our healthcare systems, which are frankly, lacking skills. We've got massive workforce shortages globally. And this is one of the few things that has promised to actually support our clinical workforces in closing those workforce gaps. So overall, I think if you think about those three things, getting your house in order and making sure that you're ready for safe, scale and pace, I would say what we need here is more haste, less speed. If you move too fast with AI and don't consider all of the things you need to get ready, you will not realize its full potential and indeed probably go through a hype cycle of thinking it's going to be amazing and not realizing it. But if you pace yourself a bit like a marathon, you will actually make sure that you have everything you need to move forward. Getting your organizations ready, getting your workforce ready, getting your data ready. There's a lot that needs to be done from the foundational aspects. And that's the space that we're in now, getting ready for the machine readable age in healthcare. So thank you for that opportunity to speak, and over to you, Blethen.
Rachel, thank you very much indeed. I always admire how you make something as simple for me to understand, or for what is a subject that is obviously complicated and across a range of areas of expertise. So a big thank you. I know that we have a number of questions, so I'll go straight into the first one. So is AI already saving lives? And if so, how?
Oh, what a good question. Yes, it is already saving lives. I've been very privileged to be involved. And when I say AI here, I mean increasing intelligence, because AI, as per the dictionary definition, is a self-adapting system. What we're doing here is moving to increasing intelligence. So machine learning, one day we will be at self-adapting systems. So the sort of intelligence I've been involved with has been based on automating decision trees and using machine learning. One project of Connected Health Cities that we were involved with, which actually took the data and then automated decision making based on the machine learning. One More Life in 10 was being saved over 100 days in the stroke pathway, and we're improving outcomes. And some of you may have seen the nice little Data Saves Lives badge, but that movement was born out of Connected Health Cities, of which I was really privileged to play a part. Another set of projects I was involved with was using data scientists to build risk stratification algorithms for kidney injury, sepsis, delirium, dementia, and a few other conditions, so that when people were admitted or walked through our doors, we knew exactly whether they needed to be on a variant of the pathway being at higher risk. And that proved to have much better outcomes for all of those groups, because what we were doing was personalizing pathways. So I've experienced lives being saved and lives being improved, and I find it really quite rewarding and monumental. But I think we've also got a duty of care to get this right. If we go too slow, we won't save lives. If we go too fast, we will have some false starts and may do harm. So the pace is what you know, us as professionals need to work out, you know, how fast we should go. It's balancing opportunity and risk here, but lives can be saved and are being saved today with this. Also the imaging algorithms, you know, I've been involved with those as well, but prioritizing diagnosis for, you know, people who've got a whole host of conditions, you know, call out Dr. Ismail Malik at Bolton and Cure.ai and the chest algorithm, that save lives and improve lives too. So, you know, we need to consider the pace we need to move at. You can't ignore this.
Yeah, so that's great. So what we're saying is AI is real. It's not just all about the future, and that you've got to get that balance right between speed and safety. Yeah,
absolutely. And that's where, as a set of professionals, we've got a job to do, because we've got to work out, you know, and we're not going to know what the next 10 years is going to look like. But if we govern this well, we can make decisions in the moment as we discover what algorithms are capable of and how they can augment humans. And indeed, another factor is the workforce. That will push us in certain directions faster because we're short of workforce. And that creates clinical risk. And so we're going to really need to look at those areas quite urgently. And that will change our risk opportunity appetite where we are short of workforce.
Yeah. And picking up perhaps a bit more of a controversial subject where some people might say there's too much hype around AI, and, you know, is AI the new emperor's clothes? What's your view of that sort of?
But it is the emperor's new clothes in some quarters, right? So already by saying that, you know, we call this AI, technically what we're doing today isn't the dictionary definition. It's moving towards AI. It's increasing intelligence, right? AI is, you know, self-adapting systems that learn and adapt themselves. And I think what hasn't helped in the markets is that investors have really thrown money towards anyone that says they've got AI. So they try and create what they call AI. And when you look at it, it's very simple decision trees in some cases. So the things that we've had for the last 30 or 40 years, you know, it's nothing new. It's just automating that. So for me, I think it can be the emperor's new clothes. And I tend to talk about increasing intelligence, us being on a journey that started probably in the 1960s with computers, but actually now, as we move into a place where we're getting our data ready for the machine readable age, we can do more. And I think AI, we need to take it with a pinch of salt. So even though I'm on the AI Council, I'd really like to say that I'm on the Increasing Intelligence Council, because I think that's probably a more accurate view. But yes, I mean, AI is thrown about as a buzzword. It's thrown about to get investment. It's thrown about to get attention, when actually we need to probably stick to more realistic language, I think, in terms of you know, hype. And then what always comes after hype is the pit of despair, isn't it? So we want to limit that pit of despair with AI.
Right. And I'm conscious that we'll have quite a lot of startups and SMEs listening who are in health tech and who may or may not be using machine learning and AI. So is that your sort of tip for them, that actually be more transparent about what it is you're actually doing with algorithms, and rather than just using AI as the buzzword?
I think so. So, you know, I empathize with them completely, because the markets quite often incentivize them to talk about AI and buzz it up, if you like. But what is good to do is say that, you know, you're moving towards AI, you've got intelligence in there. Talk a bit about what you're doing. Is it decision trees? Is it neural nets? Talk a little bit about the science that you're using. And I think actually using some scientific definitions and explaining to people really helps them to understand that we're, you know, moving towards the AI age, but pretty much nothing out there, in fact, nothing that I know of is true full AI. So all we can really say is we're moving towards AI and getting increasingly sort of digitized.
I'm conscious that we're coming to the end of our time. So one final question. Sometimes a lot of people fear AI, perhaps not necessarily in a health context, but perhaps losing their jobs and automation. I'm just wondering, how important do you think the explainability of AI for citizens and patients is, and how do we go about trying to demystify, if you like, this incredibly complex subject?
So I was given the task for a pediatric centre of explaining what AI was doing to the patients, to the kids there, right? We have to find ways of doing this, and there are ways of doing this. Sometimes we overcomplicate it, sometimes we're quite opaque about it, yeah? So I think we can find ways of explaining, and actually I can explain to my kids how these algorithms work. It doesn't, there are ways of using metaphors and analogies to actually get people to understand. So, but it is our duty to do that with the citizens. So I think for me, with citizens, with, healthcare organisations and everyone else, we need to get a standard frame of reference, standard language, and a standard set of descriptors. And that's part of the work that we need to do on standards, because once we talk the same language, we'll get a common understanding. And that's what I hope we manage to do in the coming years.
Thank you, Rachel. Great to talk to you. I really appreciate all of your help and expertise. Thank you very much.
Thanks, Bo.